Can we start?
Yes, ma'am, I think.
Okay. So, good evening, everyone, to the second session of ESI case capsule. Today, we are very fortunate to have esteemed faculty, Dr. Viveka P. Josna from AIMS New Delhi to discuss on short stature. The case will be presented by Dr. Prasitha from AIMS New Delhi, and the discussants will be Dr. Malini Ajain from Amrita Institute, Dr. Lakshmi from Hyderabad, Dr. Hedashwi from Bangalore, Dr. Jayavardhan from Pondicherry, and Dr. Sridhira from Bangalore. Over to you, Dr. Joseph. Thank you.
Thank you, Dr. Nisha. So I now request Dr. Prasid to please present the case of short stature.
Okay, thank you, ma'am. Am I audible, ma'am? And is the sound, is the slide visible?
Yes.
Okay. Good evening, everyone. Myself, Dr. Prasida Dakal, working as a senior resident in the Department of Endocrinology and Metabolism at AIMS, New Delhi. The case for discussion today is of Master A, who is a 15-year, 1-month male studying in class 9th, resident of Bharatpur, Rajasthan. And the history was given by the patient himself and the mother, and it seems reliable. He presented with the chief complaint of poor height gain for last 2 years duration. According to the patient, he was apparently well until 2 years back when he noticed that his peers in class have outgrown him in height. Out of 13 boys in his class, he used to stand in 6th or 7th row in assembly line until 2 years back. Thereafter, he gradually started standing in front rows, and from last 1 year, he is standing in the very first row. No previous height records.
Dr. Prasid, what do these three mm, points which you just said tell us about the growth velocity as per the history?
Ma'am, the 3 points tell us that the growth failure has been of recent onset, only of last 2 years duration. It was not present before that. That is the first clue we get from the history. And apart from that, it is likely related to puberty because uh, possibly his peer groups in the class have must have attained into the puberty and have outgrown him in the height, and he remained short. So these two clues, one of recent onset and other possibly related to puberty, these clues we can get from this history.
Right. Please carry on.
And there were no previous height records available for comparison, and there was no history of disparity in growth of limbs and trunk. He hasn't developed beard and mustache yet, and no history of heaviness of voice or nocturnal penile tumescence yet noticed by the patient. And he also has not developed axillary or pubic hairs yet.
So what is the history of, why have you taken this history of axillary and pubic hair appearance?
Um, Ma'am, after exploring the history of the short stature, on leading question, he also gave history of delayed puberty. That at 15 years he had not yet started having a beard and mustache. So I asked the history of axillary and pubic hair to assess whether he has already entered into puberty or not. So here he has not entered PWARC, which possibly means that which increases the possibility of CTGP in this patient.
Right. Please carry on.
There was no history of delayed height gain in parents or elder sister. The father started saving at the age of 16 and a half years, and mother had menarche at 14 years of age, and elder sister had menarche at 13 and a half years of age. Coming to the birth history, he was born out of non-consanguineous marriage. There was no history of any maternal illness, smoking, or alcohol during the pregnancy. It was a
Is
term.
Please hold on. What is the importance of taking history of consanguinity in a short stature boy?
Ma'am, there are different types of growth hormone deficiency, type 1, 2, and 3. Type 1 may have a autosomal recessive inheritance, and history of consanguinity becomes important in that case. And many cases of RTA, such as partial RTA, they may just present with short stature only without any other overt sign. And hereditary partial RTAs also have, some of them have a recessive inheritance, autosomal recessive inheritance. So this history was taken.
Right. Please carry on.
It was a term vaginal delivery at hospital. The birth weight was 2.75 kilogram, and the birth length was not known. There is no history of prolonged jaundice, seizure, hypoglycemia, or ICU stay.
What is the importance of this taking this history of prolonged jaundice, seizures, and hypoglycemia?
Could
Uh,
point to GH deficiency, ma'am. GH deficiency, the babies can have neonatal jaundice, neonatal hypoglycemia. And this hypoglycemia can lead to seizures also. And in congenital hypothyroidism also, there could be prolonged jaundice.
Yes, ma'am. There was no history of small phallic size or undescended testes at birth.
So how is this history relevant? Small phallic size and undescended
Multiple
testes.
pituitary hormone deficiency, you would present as small phallic size or undescended testes, and sometimes, ma'am, idiopathic hypo plus growth hormone deficiency would also present in the same manner.
Right. Carry on.
Coming to the developmental history, the child had achieved motor and speech milestones at appropriate age. The scholastic performance was good.
What history did you take to conclude that the motor and speech milestones were normal?
Ma'am, in the motor milestone, we have gross motor and fine motor milestone, which we need to ask. Usually, in coming to gross motor, at 6 months of age, usually the child sits with support. At 8 months, sits without support. At 9 months, the child can stand with support. At 12 months, can stand without support. 15 months can walk. 18 month can run, and at 2 years he can ride a bicycle. Coming to fine motor, at the age of 18 month, the child can scribble. At the age of 3 years, the child can copy a circle. At 4 years, can copy a cross. And at 5 years, they can copy a triangle. And in speech, at 6 months, it's usually a monosyllable speech. At 9 months, a bisyllable speech. 12 month, it's usually 1 to 2 word vocabulary. 18 month is 8 to 10 word vocabulary. And after that, the child can speak in sentences.
Carry on, please.
Coming to negative history, there was no history of poor or excessive weight gain, and there was no history suggestive of any chronic systemic illnesses, and there was no history suggestive of Cushing's syndrome, hypothyroidism, hypoparathyroidism. There was no history of headache, vomiting, visual field cuts, head injury, head surgery, or radiation in the past. In the nutritional history, the child was exclusively breastfed for 6 months of age, and bottle feeding was done up to 2.5 years of age. The current diet constituted of 2100 kilocalorie, which was appropriate for his weight. Protein constituted 50 gram was total 50 grams per day, which was also appropriate, and the calcium intake was 1000 mg per day, which was slightly lower than the recommended intake. Coming to the personal history, the sun exposure duration was of around 1 hour every day, and the timing was around 11 a.m. to 11:30 a.m. and 12:30 to 1 p.m. with a 18% body surface area exposed directly to sunlight.
Why have you taken this history of sunlight exposure?
Sunlight exposure is required for vitamin D synthesis, and vitamin D, although patient doesn't give any history of obvious history suggestive of any metabolic bone disease, this history was taken just to ascertain whether the vitamin D ascertain the possibility of vitamin D deficiency in the child, which is required for normal growth and development.
How much is adequate sun exposure?
Uh, Ma'am, usually the body surface area exposed is around 10 to 15% in most of the patient. So when that area is exposed to 0.5 minimal erythemal dose, we require exposure of 10 to 15 minutes in white skin people and 60 to 90 minutes exposure in dark skin.
Okay, let's carry on.
Coming to family history, he was second in birth order. There was no history of short stature in siblings or parents, no history of any parental dispute or physical or mental abuse to the child. Uh, there was no history of any known chronic illnesses, no previous history of tuberculosis, thyroid disorder, diabetes, hypertension, or recurrent blood transfusion in the child. Coming to the summary of history, this case is of 15-year 1 month, apparently healthy male who presented with 2-year history of poor height gain and lack of development of secondary sexual characters along with delayed PUARC. So the differential based upon this history, first would be constitutional delay in growth and puberty. Second would be a multiple pituitary hormone deficiency. Third, hypogonadotrophic hypogonadism. And the last one is the systemic illness without any overt features such as celiac disease or partial distal artery.
So why have you kept the constitutional delay of growth and puberty as the first among the features based on history?
The constitutional delay in growth and puberty was kept because the child had a history of delayed height gain, delayed puberty, as well as delayed PUARC. And also because it is the most common cause of this condition, especially in male age group. And other reason of keeping this was that there was no history of any undescended testis or micropenis at birth, which made the diagnosis of hypogonadotrophic hypogonadism less likely in this child. So the possibility of CDGP was kept first.
What are the points against CGTP?
Against, there was no family
No.
history of delayed
Family
puberty or
history.
growth in the parents, also in the siblings. That was one point not supportive.
And height velocity has also been reducing. It's not normal height velocity.
Yes, ma'am. Height velocity was also reduced, and that also indicates it's not a CDGP.
What is the usual pattern in CGTP of height velocity?
In CDGP, the child crosses centiles by around 2 to 3 years of age to reach the third centile of the height, and then he grows parallel to that third centile and enters puberty late. And although enters puberty late, after the onset of puberty, he again crosses the centile upwards to reach his mid-parental height centile, and the growth velocity is usually normal in this child.
So why have you kept the second possibility of multiple pituitary hormone deficiencies?
Ma'am, like growth hormone deficiency along with gonadotropin deficiency can also present with similar history of delayed puberty and delayed height gain. Although delayed PUARC was not supportive for the same, I had kept it as a secondary, ma'am.
And also multiple pituitary hormone deficiency, in that case, growth hormone deficiency would present quite early in quite early years. Maybe in first decade here, a child would have been shortest in the class throughout. So I mean, still hypogonadotropic hypogonadism is a possibility, just provided undescended testis is not there. But MPHD would present quite early.
Okay. So there are no clear features of systemic disease, no features of celiac, but still why have you kept it as a possibility?
Other
no
celiac
features.
diseases may present with overt features, but celiac disease and partial RTA are conditions where they can present just with short stature only. So based
Monosymptomatic presentation is
cannot
always a
rule out.
possibility.
Right. So please proceed.
Coming to the examination, the blood pressure was normal for his age in all the four limbs, and there was no discrepancy. There was no trocheus sign. The pulse was 74 beats per minute, regular euvolemic, no radioradial or radiofemoral delay. The respiratory rate was 33 per minute, temperature 37.2. No pallor icterus, lymphadenopathy, clubbing cyanosis, or edema was present. Now coming to the anthropometry, his height was 140 centimeter with a height age of 10.5 years and a height SDS of minus 2.9 compared to the mean of the given age and ethnicity. The weight was 56 kg with a weight age of 16 years and a weight SDS of plus 0.23. The upper segment, lower segment ratio was 0.79. Arm span was 137 centimeter, and there was no unicoid proportions. The BMI was 28.57, which was plus 2.52 STS, and which was more than 90th cent. So here we can see that the height was affected disproportionately compared to the weight. The mid-parental height was 168 centimeter with MPH STS of minus 0.811. Coming to the SMR, the child was pre-pubertal with a testicular volume of 3 cc, both the testes, P1, and the stretch penile length was 5.5 centimeter, which was just at minus 2.5 ST of the given age and ethnicity, and the axillary hairs were absent.
Okay. What is the significance of height, age, and weightage?
Ma'am, we can differentiate between whether if it's due to a systemic illness, the weight will be disproportionately affected compared to the height. It will be weight age will be lower compared to the height age, but in endocrine condition, the weight age will be higher than the height age.
Also,
What
ma'am,
is this?
height age here gives us a fair idea when the actual pathology began. I mean, 10 until 10 and a half years of age, child was growing quite well. So this whatever has happened is began after 10 and a half years of age.
Right. Right. So, what is the significance of calculating the MPH?
It gives the genetic
whether-
potential of that individual to grow, ma'am.
Tells the genetic potential of growth for that individual, isn't it?
Yes.
And what is the target height?
Ma'am, target height is normally first we calculate the mid-parental height, and if there is a difference between the mid-parental height and the 50th centile height, due to the phenomenon of regression to mean, the child is able to cover up for 20% of this difference. So the formula for target height is given as MPH plus 20% of mean height minus MPH.
And what the child, how much above and below the target height is the
Plus
child?
minus 2 standard deviations, ma'am, it's a possibility. So in regression to mean, like if parents are taller, child might end up shorter in minus 2 standard deviation range. If parents are shorter, child might end up in plus 2 standard deviation range.
Okay,
Usually
so
around plus or minus 8.5 centimeters around the mid-parental height, ma'am. Right.
within 10 centimeters of the target height, we can expect the adult height to be plus minus, isn't it?
90% of the individuals.
Yes. So, which growth chart have we used?
Ma'am, in our institute, we use the IAP growth chart for 5 to 18 years age, and for below 5 years, we use the WHO growth chart.
So why do we use this growth chart, IAP?
But other growth charts such as the CDC or WHO growth chart, they are based upon the US population. Since as per the ethnicity, the genetic potential for height differs. So the IAP growth chart is based upon the Indian population. So we use this growth chart.
Right. What is the importance of calculating the standard deviation and SDS?
It helps us to understand the severity of short stature, ma'am. For defining short stature, we take the height SDS less than -2, but less than -3 is indicative of severe short stature and it warrants urgent evaluation for short stature. And we calculate it using, first we see for that particular age, what is the height at the third centile, minus the height at the 50th centile divided by 2 will give us one standard deviation score. And then we take the height of the child minus the height at the 50th centile divided by this one SD will give us the standard deviation score for that particular child.
So here in this child, the BMI SDS was plus 2.5. So what are the causes of short stature with a increased BMI?
Usually-
syndrome, ma'am.
Yes, ma'am. Cushing syndrome can have such presentation. Hypothyroid may also have a obesity with short stature.
Monogenic condition.
Syndromic obesity can also present in short stature.
Even pseudo hypopara may also have obesity with short stature.
Okay, go ahead.
Coming to the general physical examination, there were no features suggestive of any syndromic short stature, no features suggestive of metabolic bone disease, Cushing syndrome, or hypothyroidism in the patient. The systemic.
There's some mention of nystagmus here?
Yes, ma'am.
Yes, all right, yes. Why do we look for nystagmus in a short stature?
In septo-optic dysplasia.
In septo-optic dysplasia, there can be associated.
Okay. Right. In the previous slide, you have commented upon the upper segment by the lower segment. What is the importance of upper segment to lower segment ratio?
Better to know proportionate or disproportionate short stature.
Yes, ma'am. The lower segment may be disproportionately shorter in cases of hypothyroidism, achondroplasia, osteogenesis imperfecta, and in females in Turner syndrome also.
Hypothyroid also?
Yes,
More than, and also, ma'am, at this age, patient is about 15 years of age. So I would expect a upper segment, lower segment ratio between 0.85 to 0.9. Here it is quite low. This does suggest long-leggedness as well here. Patient is having lower segment. So that again just points towards some hypogonadism as well.
Okay. Right, go ahead.
On systemic examination, the neurological examination, cardiac, respiratory, and abdominal examination were within normal limit. So coming to the summary after the history and physical examination, this was a case of 15-year, 1 month, apparently healthy male child presenting with 2-year history of poor height gain and lack of development of secondary sexual characters with delayed PUR. On examination, the finding was that the height SDS was minus 2.9 SD below the mean. And the child was pre-pubertal with a testicular volume of bilateral 3 cc, and he also had a delayed PUR with P1 and the axillary hairs were absent. So based upon this, the differentials, there is slight change in the hierarchy of the differentials. The multiple pituitary hormone deficiency would come above CDGP in this case because of the severity of the short stature in this case. The height SDS is nearly -3 in this case, which is unlikely in CDGP. So that was a finding which changed the which changed the hierarchy of the diagnosis. And since the weight was not affected much, so the possibility of systemic illness became remote after the examination. Also, hypogonadotrophic isolated hypo also became a remote possibility, because hypo alone usually they do not have such severe short stature, and other findings such as unicoid proportions that was absent in this case after in the examination.
Right. Right. Go ahead.
Coming to the first tier of investigation, the hemogram, RFT, LFT, and calcium profile, including the vitamin D PTS, they were within normal limit. The urine routine was normal. The blood pH and urine pH both were normal. The bone age was 12 years at the chronological age of 15 years. That means a 3-year delay in bone age was there. And the IgTTG was also normal.
So how much delay in bone age is significant?
More
Usually,
than 12 years, 24 months of delay is significant.
Okay.
2 years.
Right, carry on. Oh, right, carry on. And what are the causes of delayed bone age?
Most of the causes of short stature, usually they have a delayed bone age, such as the growth hormone deficiency, hypogonadotrophic hypogonadism, systemic illnesses.
CDG.
Hypothyroidism, Cushing's, all
Hypo-
will have short, delayed bone
Delayed.
age.
Okay.
Since the initial blood workup was normal, we moved on with the hormonal test. Here the TSS and total T4 was normal. The IGF-1 levels was low. Serum cortisol ACTH was low. Was normal, and but LH and testo was also low. So the child had both low IGF-1 as well as low LH and testo levels. Since IGF-1 was low, we moved on with the growth hormone stimulation test using clonidine. Here the peak GH was 4.6 nanogram per ml, and with glucagon stimulation also, the peak GH was only 2.4 nanogram per ml. So this establishes the diagnosis of growth hormone deficiency in this child. So MRI SELA was done.
Just hold on. What are the causes of IGF-1 deficient low?
It can be due to growth hormone deficiency. Other causes could be malnutrition, liver disease, overt hypothyroidism. They can also cause low IGF-1.
Okay. So you did. Somebody said anything else?
Growth hormone resistance, receptor resistance can cause low IGF.
Yes. Hypogonadism can also cause.
Yes.
Yes.
Yes, in this age, it can cause low IgF.
Okay. So growth hormone stimulation test you have done. So in that, what is the gold standard for growth hormone stimulation test or pharmacological stimulation?
Insulin.
Hence, hypoglycemia is the gold standard.
So why it was not done? Why we don't do it?
Hypoglycemia, severe hypoglycemia, side effect could be there.
Leading to
Seizure.
seizures, arrhythmias, even death has been reported. That is why centers don't favor doing that. So less risky tests are done. So clonidine stimulation test was done. So how much clonidine is given?
Usually we give 0.15 mg per square meter. We calculate the dose and we give it.
To a maximum of
0.3 milligrams.
0.25 milligrams is mentioned in studies. And what are the prerequisites before we do a growth hormone stimulation test?
Patient should be
Ideally,
Fasting.
GH stimulation test should be done in the fasting state. Then euthyroidism and eucortisolemia should be ensured. And at our center, we go for this priming, ma'am, with sex steroids in children, in girls more than 10 years and boys more than 11 years, with Tanner stage, pubertal Tanner stage less than or equal to 2. We will be giving estradiol valerate. Boy or girl, we will be giving estradiol valerate 2 mg for 3 days, 3 evenings prior to conducting the test.
So what else can be given for priming?
Testosterone enanthate 100 mg can be given 5 to 7 days prior to the testing.
And estradiol can be given
Estradiol can also be given 100 microgram.
Estradiol and what dose?
0.1 milligram for 3 days.
Yeah. What is the tablet available?
Yeah, a line oral tablet, ma'am. It's we need to give 10 tablets, ma'am. It's 10 microgram each tablet. So for 100 microgram, we have to give 10 tablets.
Binaural comes in strength of 0.05 and 0.01.
Yes, ma'am. 0.01 it comes. So we can give 10.
Okay. If we take then 0.1, we'll have to give 10. If we take 0.05, we can just give 2 tablets. Isn't it? 0.05 is that means we can do 2 tablets for 3 days.
Yes.
And then 4th day we do the clonidine stimulation test.
Yes.
And right. So what are the precautions we take when we do a clonidine stimulation test?
Ma'am, we see for the side effects such as drowsiness, hypotension. So blood pressure monitoring should be done. If the child develops hypotension, then we should give a normal saline, and the sample we can continue taking the sample even in that case.
And to prevent the child from falling, we'll ask the patient to keep. It's preferable that the patient keeps lying down during the test. Okay, when is the GH response said to be subnormal in growth hormone stimulation test?
Ma'am, with ultra sensitive assays, we less than 5 nanogram per ml is highly suggestive of growth hormone deficiency. 5 to 7 nanogram per ml is a gray area, and above 7 it's unlikely.
Sufficient.
Okay. So why 2 tests are required? 1 test should be sufficient.
Specificity of each test is less, so that's why we do 2 different tests so that the specificity is more.
If there have been a recent since we know that growth hormone is secreted in pulses, so if there was a recent growth hormone pulse, and the pulsatile activity is at nadir, and we are doing stimulating at that point, the growth hormone may not get stimulated. So the test may come like low growth hormone. So we usually do 2 tests to confirm, to increase the specificity of the finding.
Okay. So MRI, why do you do in all patients with GH deficiency?
First, to look for any lesions in the pituitary, such as craniopharyngioma or other pituitary tumors, and other it could also be like congenital defects such as pituitary hypoplasia, empty sella, or stalk interruption syndrome, where there is a short stalk with ectopic posterior pituitary bright spot. These findings, to look for these findings, we usually do MRI.
Okay. Here in the investigation, you see the LH and testo are also low, isn't it?
Yes,
So there are 2 axes affected,
yes.
isn't it? The growth hormone as well as the gonadotropes. So, so what do you think is the diagnosis?
Ma'am, it could be since we have established the diagnosis of growth hormone deficiency by doing the 2 stimulation test. So we are more or less sure of the diagnosis of growth hormone deficiency. The gonadotropin deficiency in this case could be as a part of multiple combined pituitary hormone deficiency, or it could also be self-limited delayed puberty, which can spontaneously enter into puberty later on.
So how will you differentiate? How will you differentiate it?
To differentiate between hypo and CDGP, we can do a GNRS stimulation test, where if the peak LH response is more than 8 international unit per liter, it supports self-limited delayed puberty over hypo.
Okay, right. Right. Carry on. Carry on. So GNRS stimulation test you did in this patient. And how do you do a GNRS stimulation test?
We usually use triptorelin, ma'am, 0.1 mg per square meter with a maximum dose of 0.1 mg. And we take the samples for LH at 0, 2, and 4 hours. And if it's more than 8, then we take which supports the diagnosis of CDGP over hypo.
0, 1, 2, and 4. No?
Yes, ma'am. Some people mention 1 hour also. Some say 0, 2.
Right. So in this patient, if the post stimulation at 4 hours and post GNRS stimulation, LH at 4 hours is 9, then what will be your diagnosis?
So, since this patient didn't have any micropenis, undescended testis, and also had associated delayed PUARC, the diagnosis of hypo was questionable even with the clinical features of the patient. And if the GNRS stimulation is showing a LH response of above 8, then in this condition, I would keep the possibility of self-limited delayed puberty over hypo.
Okay. So, so you keep the possibility of growth hormone deficiency with delayed puberty, right?
Yes, ma'am. So the final diagnosis here was growth hormone deficiency with delayed puberty, which could be a self-limited delayed puberty or a hypogonadotrophic hypogonadism. The diagnosis of growth hormone deficiency was based upon the auxological criteria, which showed a height SDS of minus 2.9, a bone age delay of 3 years, low IGF-1, and non-stimulable GH with clonidine and glucose. And delayed puberty was established because the patient had a testicular volume of bilateral 3 cc with a low serum LH and testosterone.
Okay. So how will you manage the patient?
The current management plan will be to start with recombinant human growth hormone at a low dose of 0.175 mg per kg per week, and then monitor for the growth velocity, change in height STS, bone age, serum IGF-1, T4, and cortisol levels, and then also monitor for any spontaneous entry into the puberty. And looking at the response every 3 monthly, we can titrate the dose of the growth hormone and also take decision about induction of puberty if it's required.
Okay. So what are the adverse effects of growth hormone therapy? What would you look for?
Idiopathic intracranial hypertension, slipped capital femoral epiphysis, progression of scoliosis, then unmasking of some hypothyroidism could be there, unmasking of adrenal insufficiency can occur, edema can occur, joint pains, arthralgia, carpal tunnel syndrome.
LTM joint pains.
Right, right. So how often would you like to call the child for for auxological measurements and tests?
First
Monthly, ma'am.
3 months for IGF-1 levels, ma'am, initially.
The first 3 months you would like an IGF-1 and what else?
T4, like free
And
T4
cortisol.
Thyroid functions.
cortisol
Thyroid
levels.
functions and
Just a T4 is sufficient, or we also will want a T4 and
T4
TSH?
TSH.
Pre-T4 and TSH both.
Why?
Then there will be
Central hypo.
Yes. That is also likely.
Somatostatins to tone can unmask central hypothyroidism.
Right. So how do we regulate the dose of growth hormone once we start? And how do we regulate the dose?
Looking into the growth velocity, uh, we need at least 6 months to get a substantial idea on the any change in the growth velocity, and at a year we can also look at the change in the height SDS. So depending upon that, if there is a suboptimal response, like change in height SDS is less than 0.3, or the growth velocity is less than 5 centimeter per year, then we can consider escalating the dose. And also
Any
depending
other?
on the IGF-1, serum IGF-1 level, we should target
IGF-1
normal range of serum IGF-1, and that also helps in deciding about the dose.
Okay. What factors affect the growth increment after we start growth hormone therapy?
Ma'am, the response to growth hormone therapy depends upon the age at which the growth hormone was initiated, the severity of the stature, the peak GH response during the GH stimulation test, the target height, and the integrity of other axes, whether they are well managed or not. All this will impact upon the growth height response to growth hormone therapy.
Genetic potential of the child will also be a deciding factor in the response.
Yes, yes, yes. So, if puberty does not set in, like he also has LH low, and you would like to monitor the child, start growth hormone therapy and monitor him for how long before you start the testosterone?
He is now 15 years at 15 years of age. So he presented to us with a concern of short stature, and delayed puberty was detected during the evaluation. So puberty was not of a much concern to the child, and also also there were few findings that were not suggestive of hypo in this child. So we can wait for at least a year and see if he is spontaneously enters into the puberty or not. Since if he doesn't enter into the puberty, and lack of pubertal sex steroid will also hamper upon the response to growth hormone therapy. So after a year, looking into the growth hormone response, the advancement in the bone age, and whether he enters into the puberty or not. If not, we can think of starting pubertal induction at that time.
So how will you induce puberty?
We can induce
Suppose at 1 year
yes,
he enters puberty, so then it's fine
yes.
because he's likely to enter since his GnRH stimulation test was stimulable. It was more 9. So if he enters puberty himself, then
Ma'am, in that condition, we need not give any pharmacological measures for induction of puberty. We can just
right,
control the growth hormone.
right. If he now he has a bone age of 12 years.
Yes.
So you are giving him growth hormone. 1 year you say you will wait, and then after another 1 year you will if he doesn't enter into puberty. So what will you do? Will you evaluate again?
Ma'am, since in case we have already done a GnRH stimulation test once, then uh, we need not reevaluate him. But if we have not done now, and after 1 year, if he doesn't enter, then we can evaluate at that point of time. And induction of puberty at that time will also depend upon the concern of the patients. If he is concerned about the delayed puberty, then we can consider starting pivotal induction at that time.
So how will you induce puberty in him after 1 year if he doesn't start
We can
himself?
either give gonadotropins, or we can give a testosterone. For
Low-dose
gonadotropin,
testosterone and low-dose testosterone started initially maybe for 3 to 4 few doses, if they enter into puberty spontaneously, that again points towards self-limited delayed puberty. I mean, it does help with CDGP. If doesn't enter into puberty after that, then we can consider with gonadotropins moving ahead. But initially, if we were to start with, to give him some secondary sexual characters, we'll start with at least 50 milligrams of testosterone monthly. IM.
So, right. So, how long will you give him? Suppose he is not entered into puberty. You will start with testosterone. So, give him the benefit of induction of appearance of secondary sexual characters, and you will keep monitoring his own development of testicular size and his. Is he likely to enter puberty himself?
Ma'am, if the GNR stimulation test is showing a LH of 9, then probably he may there are chances that he may enter into the puberty. We can also at follow-up we can also look at the LH levels. So in a study from our own institute, a basal LH level of 0.8 in girls and 1 in male indicates the entry into the puberty. So that could also be one measure to see at follow-up if you are not inducing.
Right. So, growth hormone, the patient asks you, how long is this going to, what is the cost of therapy? That is, patient asks you, what will you tell him?
Ma'am, the usual one that we prescribe in our institute, it costs around 180 rupees per unit. So it comes in a vial of 4 units. So it costs around 720 rupees. So per unit cost is 180. So the cost depends upon what unit is being given to him per day.
So, like this patient is 56 kgs.
Yes, ma'am.
So you will like to start in a dose of
56. I need to calculate. 56 into 4.2 units per day.
okay. So and you said you will monitor by the patient's height gain and IGF-1 levels.
Yes.
And then you call him after 3 months, 6 months, when you consider and the IGF coming in the lower normal range now. So how will you then increase the dose based on weight? Right. So till when will you give him growth hormone therapy?
We can consider giving growth hormone till the child has achieved his target height, or we will be monitoring the growth velocity. When it is less than 2 centimeter per year, we can do a bone age. And if the epiphysis has fused, then we may consider stopping GH at that point, ma'am.
Her target height is reached.
Okay, target height is reached, and the epiphysis, like in what age in boys and in what age in girls?
It's usually 16 in boys and 14 in girls.
14 in girls.
Right. So, what are the conditions in which short stature condition in which we have specific growth charts to that disease?
Turner syndrome and Prader-Willi.
Downs.
Also
Achondroplasia.
Achondroplasia, yes.
Yes.
And Prader-Willi.
Okay. Prader-Willi also has?
Yes.
Okay. So, what are the determinants of prenatal growth? Is growth hormone required?
Usually, prenatal growth is more dependent upon the maternal nutrition.
Maternal nutrition.
Deficiency. IGF-1 and placental IGF-2.
And the determinants of postnatal growth?
The maternal influences reduces, and it mostly depends on growth hormone IGF-1 axis after the postnatal period.
Thyroxine and
Also,
Insulin.
Also the genetic potential, ma'am. After 2 years, mostly the child will grow along his genetic potential if other things are not.
So I think we are done with the case.
Thank you, ma'am.
thank you.
Thank
you,
you,
ma'am.
everybody, for participating. Thank you, Dr. Prasada, for presenting.
Thank you, ma'am.
Dr. Nisha?
Yes, thank you very much for that very clear and concise presentation and the discussion. I think everyone and all the discussants also participated actively. Thank you very much, everyone. I think the highlight was the like very clear, the clarity of the ideas which were conveyed. It will help all the students who have join this meeting. Thank you very much, Dr. Josna, Dr. Prasida, and all other discussants. Thank you very much. Now we will move on to the quiz program. Dr. Nitin.
Yeah, so I would request Dr. Prasida to please stop sharing the screen.
Is it okay now, sir?
No, you're still sharing. You will see a red button, stop share. Yeah, perfect. So we shall now move on to the quiz, and all the people who have joined in the Zoom and those who are listening otherwise are free to join the quiz. The quiz is again online and software based. I'm sure all of you are now familiar with this particular software where you can answer the questions and look at the question options on your screen as well as on the Zoom platform where you are. The answer can only be given through your smartphone device that you can use. When we show you the barcode, you can enter the quiz. But for the interest of those people who joined first time, I would just go through the rules again. And the rules are simple. You need a smart device. You need to see this Zoom presentation while you're in the quiz. You need good internet connection so that your answers are captured fast. The important thing to remember is not only to answer correctly, but also to answer fast. The people who answer fast and correct get more points than people who answer correct but slow. The maximum amount of points that you can get per question is 1,000 points. This quiz has only 10 questions. All are multiple choice questions only. There is no negative marking. I would request all who are joining the quiz to please enter your correct name, because with that we are able to reach out to you for your cash prize. So I think with this, we'll get started. The first person, the top person who gets the highest number of points will be the winner. Only one prize will be given. So with this, I have shown the barcode that you can use from your smart device, or you could go to Google and type menti.com and you'll be able to enter this code. I'll wait for a minute. Anybody having any difficulty would request to please post in the chat box. If by chance anytime during the quiz, if you lose the connection or you are out of the quiz, you can always join back. This use code which you see on top of the slide will be available on most slides as we go along. At this point, you should only be able to see a question mark or a thumbs up sign. And as soon as we move on to the next slide, you'll be able to enter your name. So I think we should get started. So as soon as I press the next slide, you should be able to enter your name. With that, we have close to 100 participants today. Start with the first question. If the question there as well as mobile. Wrong. So that's it, Joanna. On to the next question. With advanced in short stature, all of the following steps. This point was discussed during the session. Was it right? Joanna is still waiting. Moving on to the third question. What of the syndrome? There is no negative marking. Right. Most of you have this correct. We move on to the next question. Okay. Moving on to the fourth question. A common expression in the exam comparing the biophysics. Options there. So fast meeting, go on to the fifth question. Informative. The options are much bigger on your screen. Definitely, Guru, hypoparathyroidism is not the answer here. Let's see how you've done. Dr. Ravindranath Reddy is leading, but we still have a few more questions to go. Similar question to the last one. So, okay, this is not the answer here, but it's the last question. This is Dr. Ravindranath is speaking. But one more question now. Directly from Williams textbook of endocrinology. Correct. Most of you have answered that correctly. So this is a table from Williams textbook. You'll see that most of them which are outside GH and IGF-1 axis osteochondrodysplasias come there, whereas histiocytosis axis here, GH insensitivity is part of within the GH IGF-1 deficiency for obvious reasons. So we've got 3 more questions now. Let's see how you've done in this question. Very simple question. To put it right again, as we can see, congenital IGF-1 deficiency could be because of abnormalities at the GHR, the STAT5 mutation, acid-labile subunit mutation, and IGF-1 gene and type 1 receptor mutation. So all these are here. Bioinactive GH has got nothing to do with congenital IGF-1 deficiency per se. You don't know who SSSS is, I request you to mention that in the chat box. Second last question. marked diabetes. So obviously what is mentioned there is severe diabetes mellitus. Obviously hypertension, tobacco and alcohol intake causes maternal factors of SGA. Move on to the last question. In the last question, you'll be shown an image before actually the question comes, and also some history. So this is a story of a 16-year-old girl who presented with chief complaints of having severe short stature, primary amenorrhea, lack of development of secondary sexual characters. You can see 3 pictures, a clinical photograph of the patient, the bone age, and another image. You have to tell the diagnosis. These images will be available on the next slide as well. Can I listen to a question? Definitely that was single thyroid. You could see it on the picture scan. I think the winner for today. So congratulations, Dr. Vijayawardhan. We will reach out to you regarding the prize. So with this, we come to an end of the quiz.
Congratulations, Dr. Jayavardhan. And thank you, Dr. Nitin, for that wonderful quiz. I hope you all enjoyed and had a wonderful session. So we'll meet next month, April last Wednesday. The next session will be on precocious puberty by Dr. Vijay Sai. Thank you all once again. Thank you, Dr. Viveka, and thank you all the discussants and presenters. Thank you all.
Thank you.
Ma'am.
Thank you. Good night. Bye-bye.